Hello, everybody. So this is my last presentation in this session. I'm Laurent Brochard, working at the University of Toronto, and I'm going to discuss the future of mechanical ventilation, a very uncertain topic, as you will see. I've been working with a number of companies which are listed here for research grant or mostly for equipment. So the first good news is that in the future, there will be no more patents. So on any ventilation tools, all types of monitoring will be available and will be implemented on any ventilator, measurement of lung volume, electrical impedance tomography, diaphragm EMG. All modalities of ventilation will be available, especially the proportional modes of ventilation, which are so useful and important, but are underused, like PAV and NAVA, but also the automated system like SmartCare, ASV, and IntelliVent. Of course, this is a dream. This will not be the case, as you know. We will continue to have competition and to have this limitation that sophisticated tools will be available usually on one brand. However, there are a number of features which should be available everywhere, or at least should be available for any ventilator company as a strategy. Safety, of course, is a key question, and safety concerns lung protection, but also diaphragm protection, as I will show you. I think the future should do much better in terms of patient-ventilator interaction, especially monitoring and having a smart monitoring and analysis of this interaction. The question of automation versus simple incentive for the clinician, I think, is open, and there is no definitive answer to that. But also, and I will finish with that, we need new solutions. As the pandemic showed us, we were not prepared for having a green solution, sustainable solution, nimble and cheap. And I will briefly mention the fact that we really were not good on this part. So lung protection during assisted ventilation especially we need to make progress. I know this is an hypothesis that patient can have self-inflicted lung injury, but I do believe this is a real risk for patients with a high respiratory drive. And these patients under assisted mechanical ventilation may go undetected because the usual monitoring do not tell us that. This is a very classical and nice example of an experimental study by Yoshida. And you see, if you look at the airway pressure, it's the same on the right and the left. But if you look now at the esophageal pressure, on the first part, it's passive ventilation, esophageal pressure goes up, and the difference between the two, the transpiratory pressure, is limited. But once the patients can breathe at the same time of the ventilator with synchronized ventilation, you see it makes the lung injury much worse. And with the monitoring we have, looking at airway pressure only, we cannot achieve that. So esophageal pressure monitoring and transpiratory pressure is a possible solution and is already implemented on some ventilator. But we have simple tools which could be everywhere. This is a technique showing that if you do an occlusion, just a simple and expiratory occlusion, you can measure from the airway pressure a negative pressure drop. And this negative pressure drop is usually higher than what the patient is doing during standard ventilation. But with a formula, you can recalculate what is the mean pressure generated by the patient and also the mean transpiratory pressure. So such tools should be implemented in the future as an automated calculation, or just as an information for the clinician to tell what the clinician could do. And I think it should not be only lung protective ventilation, but also lung and diaphragm protective ventilation. I will not go through the details of these complex graphs. On the right, it shows that there are many factors which can interfere with lung ventilation, with protective ventilation of the lung and of the diaphragm. And sometimes they may be conflicting, but we need to have a better understanding and information at the bedside to protect the lung first, but then to protect the diaphragm from atrophy or from excessive use. And in this paper called Diaphragmatic Myotrauma, the different mechanisms were detailed, including over assistance where the diaphragm is not working at all. Even if you're in pressure support ventilation, this happens. Under assistance when the diaphragm is working too much, or asynchrony and eccentric contraction when the diaphragm is contracting during the expiratory phase, like during ineffective efforts or reverse triggering. So we need monitoring for that. And again, we have the tools. One of the very important tools we should use much more is the information about the drive, which can be estimated from the airway occlusion pressure, the P01, which is does not require full occlusion, just 100 milliseconds of an occlusion. You have an example here on the left of a patient with a high respiratory drive, close to 4 centimeters of water, and a patient with very low respiratory drive, below 1 centimeters of water. And why should we use that? Because we have shown recently with Irene Telias in the Blue Journal that especially for under activity, if you wish, very low drive because of excessive assistance or sedation, this is very well detected by P01. If the P01 is below 1, you can be sure that the effort of the patient is not sufficient to maintain, for instance, activity of the diaphragm, and the diaphragm is at risk of atrophy. And again, if the P01 is too high, like more than 3.5 or 4, you may expect injury to the diaphragm. Also, the driving pressure has become a classical tool for passive control ventilation, but it's also very useful for assisted ventilation. Proportional assist ventilation, PAV, is the mode where you have automatically this calculation. You don't need to do any additional maneuver. And the group of Katerina Vaporidis and Dimitris Georgopoulos showed very nicely that most of the patients, when you give the control of the tidal volume, keep the driving pressure in a reasonable range. But it's also possible to measure this driving pressure, so plateau minus PEEP, if you wish, during pressure support ventilation. It's not possible on every ventilator or in every patient, but Bellani and coworkers even suggested that it's associated with the outcome during pressure support ventilation. So one of the key questions for which we need help from ventilator is what dose of ventilation should we deliver? Not enough is letting the patient go into respiratory distress, lung and diaphragm injury. Excessive is also putting the patient at risk for the lung and the diaphragm. But one additional information we need is synchrony, because asynchrony are specifically associated with either insufficient dose of support or excessive dose of support. Let me give you 2 examples. So this is from a randomized trial where you see a patient having a lot of double triggering and breath stacking. So probably this patient is not adequately assisted. You need to either refine the ventilatory measurements or maybe give more sedation. By contrast, this patient is passively ventilated, but has a lot of double cycling due to reverse triggering. So this is not easy to be detected, but it's possible. And we have studies from different groups in the world showing that from airway pressure and flow, you can detect very reliably whether it's reverse triggering inducing double cycling or it's double triggering. This is a study by Pablo Rodriguez and the group in Argentina. And this is a study by Luis Blanc, who has designed a system to detect asynchrony. So it's feasible, it's possible, and that should be the future of mechanical ventilation. What about automation? As I say, there is a debate between having closed loop or open loop, or if you want simply incentive for the clinician. I've been working for many years with a system called Smart Care, which was reducing the level of support until a minimal level was reached, which was an incentive for the clinician to separate the patient from the ventilator. And it worked well in the Cochrane meta-analysis showed that it reduced the duration of ventilation and the duration of ICU stay. But people do not like it. People don't use it. And I think there are reasons for that. Some are good reasons. Therefore, it may be sometimes better to have only some incentive for the clinician to say, maybe this is what you should do. And this is open for, new ideas. But let me finish with that. We are very smart. We have very sophisticated tools. We have very great, good, expensive ventilators. But look at what happened. Nobody expected that. We did not have enough ventilators. And this was in the medical press, this was in the lay press, and you had centers who had to share ventilators for several patients. This is incredible, and this was completely not expected. So we need to incorporate this in a future of mechanical ventilation. This is a need which is not fulfilled now. And at the same time, we had all these ventilators. People all over the world decided, well, we need to start from scratch and to build new ventilators. This was a competition in Canada. On the top right, you see an automated system squeezing a bag. On the bottom, you see a proposal from Milan and Canada, including a Nobel Prize in physics, saying, oh, we want to help and to build new ventilators. So incredible time. The WHO has been looking for innovation. And this is, for instance, system on which we have been working because we were looking for solution, not using two pressure sources for ventilators, because you don't have oxygen and compressed air everywhere. So this is the oscillator, very simple system delivering reliable controlled flow ventilation, or transport ventilators studied by Dominique Savary and others, which could be used also as a bridge to more sophisticated ventilators. So we need to incorporate that. This was not expected, and this should be part of the future of mechanical ventilation. If you're interested by having more dialogue on this complex issue, please follow us on our blog, coemv.ca. Thank you very much.